Welcome to another episode of the Residency Match Insiders, and today we're going to talk about something very, very important and useful during inpatient rotations: electrolyte replacement and PRN orders. Why? Because when you're doing this rotation, you will get calls from nurses, from everyone about abnormal labs and also PRN orders. They need an answer right away. So this will come to you over time with just practice and repetition. Um, from the beginning, you may need to check on things here and there, but with practice and repetition, it will just come second nature. Okay, so we'll start with some of them, the most common. Let's start with the PRNs, okay? PRNs for blood pressure, hypotension, a PRN. Um, what can you use for a patient that the nurse calls you saying, oh, his blood pressure is trending down, is now 85 over 60, and he was admitted for sepsis. While you have to still look for other reasons to why this blood pressure is trending down, like bleeding or just a sepsis, then you have to do something right away to increase his blood pressure. Regardless of this patient being dialysis or being fluid overload at this point in time, you have to do something. Like what? You could give him a bolus of normal saline. Usually, if the patient is young and has no other pathologies, cardiac pathologies, you could use a 1 liter of normal saline. That could be fine. A stat. Um, or if the patient has other pathologies like congestive heart failure or ESRD, or is currently hypervolemic, then you could use something less like 250 cc's of normal saline or 500 cc's of normal saline. But let's say you already use 1 or 2 boluses and his blood pressure is still low, so you're thinking, there's too many fluids already, you cannot give more. What else can you give? You can give albumin. And the way albumin comes here, it comes in packages. Usually the one for hypertension events that we use is the albumin 25%. It's an IV, it's given as a piggyback, and you can give up to 2 doses before being concerned and start thinking about something else. So that will be your second step until you figure out what else can be going on in this patient. Is the antibiotic effective? Is he losing blood somehow? Is he volume depleted from diarrhea from the antibiotics he's receiving? Has he been vomiting? So it gives you some time to figure out things. If none of these work, then you can escalate to things like Levofet, for example, a vasopressor therapy. Okay, so that's the initial for hypotension, right? Next one, we're gonna do PRNs for tachycardia. And make sure you realize that this tachycardia is not coming from sepsis, as the tachycardia from sepsis doesn't really benefit from you trying to control the rate. Of course, the nurses are not going to realize that, but you have to give more context to them, saying this patient has sepsis and this is the reason why he's tachycardic. As long as we control the sepsis or we continue treating the sepsis, this tachycardia will improve. Or maybe this tachycardia in the setting of sepsis is coming from persistent dehydration. So you have to explain those things because the nurses are already busy. They don't know all what is going on with this patient. You know because you have more information on your hands. So if a patient is tachycardic, let's say, has a known history of atrial fibrillation, and his heart rate right now is 140, and you realize this is not SVT, this is not from sepsis, then what can you give to try to help with this tachycardia fast? Because the concern is that he is very tachy for a long period of time. So while your oral beta blockers, your oral calcium antagonists are working, you have this patient on 12.5 BID of metoprolol tartrate, while that is working and you're titrating up that to the maximum tolerated, you could still have episodes of rapid ventricular response. So what can you give if that is happening? You could do IV metoprolol 5 milligrams, PRN, tachycardia more than 120. You could do cardicem 5 milligrams or 10 milligrams IV, PRN, tachycardia more than 120. And those are the most common PRN orders for RVR. While you figure out why is this patient having a persistent RVR, you could work out your way on figure out if this is sepsis. You could call cardiology to see does he need advanced therapy for this RVR, like digoxin or combination of beta blocker and calcium channel antagonist. Okay, next one. Why we don't do POs for things like that is because a PO medication for tachycardia will take a while for it to work, and what you need in the inpatient setting is you need fast results. Not always, but when it's appropriate and it's a safe move, then it's appropriate to do IV, not PO. And next one, for fever, the most common one used for adults is acetaminophen or Tylenol. We have it on POs, on tablets, and rectal. IV forms are available, but rarely used except for children. And you can use either or, but there's a big price difference from PO to IV, and I think PO even rectally could be more than enough. We use a lot of rectal Tylenol and rectal aspirin on patients with strokes. You can also use ibuprofen if Tylenol is not working. You can also use ibuprofen. Those are the most common ones known in the hospital. We don't have metamizole in the United States as a available therapy, neither IV nor PO. Next one, anxiety. PRNs for anxiety. It's very common that in the inpatient setting, the nurses will call you and say, "Hey, this patient is too agitated. She is crying and she is breathing very fast." And while you realize that, or while you did your best to identify that this agitation is not coming from pain, it's not coming from shortness of breath, from pneumonia or a PE, it's not coming from something else that could be part of her reason to be in the hospital, and you could fix in a different way. There are ways to treat anxiety and agitation. So if it's anxiety, the most common ones that we have for anxiety, it's Ativan. You can start from 0.5 milligrams or 1 milligram IV. You can also do oral, because anxiety is not a life-threatening condition, but it needs to be addressed for comfort of the patient. You could do either or. It's more of an art who gets IV, who gets PO. If a patient is stable and he has had all his treatment for all the other things and he's anxious and crying and restless, I will do PO. If the patient is in the same situation, already treated for everything, but because he has dementia, he got very agitated and he is up and out of the bed and yelling and screaming and threatening nurses, I will do IV. So it depends on what's safe. Of course, for all these situations, you have gone through all these steps before using these medications, right? If a patient is agitated, before using medications, and this is very important that you remind yourself when seeing a patient or call for a patient with agitation, because you have to explain this to your attendants, why do you use this medication? You have to really go through things like you went to see a patient, you assess his condition, you realize that other measures couldn't be taken, like soft restraints, mittens, and posse beds, and maybe just a seater next to the bed. Um, those reassuring steps before you use the medication. Your medication was the last resource, and you had to use it for that reason. Next one, hypertension PRNs. So we did hypotension. Now hypertension, and this is a very common call from nurses in the hospital, because hospitals have parameters on what is considered high, and you will be surprised that in American hospitals, a systolic blood pressure of 160 and above, it already raises concern and on any patient, and they don't like it that high. So there could be many reasons why the blood pressure could be that high, right? So first you went through the steps to make sure that you find out why is this patient's blood pressure elevated. So if there is no pain, if there is no fever, there's no what else causes I don't know, distress, anxiety that's raising this blood pressure, and then it's really elevated to a point that you yourself feel uncomfortable, um, then you can use medications such as hydralazine. We use it either 5 milligrams IV or 10 milligrams IV, PRN, high blood pressure more than 100, um, systolic more than 160. You can modify your parameters to when to give. I usually do more than 160 if the patient, it depends, if the patient is young. If the patient is older, I am more permissive, maybe 170. And it depends on you and what is your level of comfort and what guidelines are you using. Like for me, on the geriatric patients, I like to be a little more permissive, and I'm not very aggressive on that. So yes, make sure that you keep in mind things like age when giving PRNs for hypertension, okay, and you report this to your attendants. Another one that you can use is labetalol. Labetalol comes in 5 milligrams and 10 milligrams IV. You can use that IV only. And let's say this patient is on med-surg unit. In a med-surg unit, you cannot use IV antihypertensives. Depends on the hospital. I found that most hospitals don't let you use IV antihypertensives in a med-surg unit. Otherwise, this patient needs to be on a telemetry unit. So if that's the case, you can use still a antihypertensive like clonidine. Clonidine 0.1 or 0.2, it's a antihypertensive that you can use orally, and it's very fast acting, very effective too. Remember to be careful on those patients that you're going to use an antihypertensive on request of the nursing staff, because you have to think about the context. When are you using these medications? You're going to use a medication as a PRN, make sure you went to see this patient and said, okay, this patient is not having a stroke, and you're okay to give an antihypertensive. Why? Because if your patient is having a stroke and you lower the blood pressure, you're making this stroke worse. So be careful with that. And diarrhea, for PRNs for diarrhea, Imodium, the most common ones, PRN for every loose stool, and that ends the PRNs for common conditions in the hospital. Remember to report all the PRNs that were given overnight to your attendant in the morning. Why? Because this report of you saying this patient received 2 milligrams of IV Ativan overnight due to anxiety, or he received 2 doses of hydralazine PRN for hypertension overnight, it should make you think about your current therapy and see, okay, maybe his current antihypertensive regime is not enough. I have to, while working on the rest, I have to start increasing his home medications. Maybe he's on amlodipine 5, bring him up to 10. And if he has depression and anxiety disorder already, and he is on Prozac 10, bring him up to 20. and see after those changes how much more PRNs he needs. All right, and then quickly let's go to the electrolyte protocols and the PRNs for electrolytes. And I have it open here, but for the ones that we can always replace, for sodium, we cannot replace sodium, so forget about that. The nurses will sometimes call you, hey, what do you want to do with the sodium? And the sodium, you have to give them an explanation, because why? Because they document all what they talk to you about on their notes. So if they ask you about sodium, then maybe your answer is, well, we're giving this patient Lasix because he has decompensated heart failure, which is driving his sodium high, or he's on IV fluids at a gentle rate to see if dehydration is the source of his hyponatremia. And hypokalemia, low potassium, replacement can be either IV or PO. Usually it is potassium chloride at 40 milliequivalents. IV or PO, it can be 20, it can be 40, it can be up to 60 given through a peripheral line, but beyond that, you can use a combination of PO and IV if it's very low. And as long as patient can take PO, you can do PO only. But if you need, it is very very low, and you need to be fast and safe, then you can use IV. Just remember that 40 milliequivalents of IV potassium chloride runs on 4 hours. So if your goal is to discharge that patient today, and you have to replace electrolytes before discharge, giving the IV form might take 4 hours. Next is calcium. How do you replace calcium? The most common way that we have in the hospital is calcium gluconate, and you can use, it depends on how low the calcium is, but you can use anywhere from 1,000 to 2,000, and just make sure that before correcting calcium, you calculate what the corrected calcium level is, or you ordered an ionized calcium, which is the most accurate measurement of calcium in the blood. And that's very important that you mention to your attendants that you didn't replace calcium just because it was low on the BMP, but you replace it after correcting it with your formula or by requesting an ionized calcium. Next one is magnesium. Depends on how low the magnesium is. You can give 1 gram, 2 grams, 4 grams IV, and the goal is to have it above 2. Same for phosphorus. For phosphorus, you can give a combination of either potassium phosphate or sodium phosphate, and it comes either on 15 millimoles or 30 millimoles, and it's just to raise the phosphorus above a level that you feel comfortable, which usually is 4. And for cardiac patients, you will read on cardiologist notes that they always say to keep potassium and phosphorus above 4 for the potassium, and for phosphorus above 4, and magnesium above 2. Why? Because it is thought that when these 3 electrolyte levels are normal, there's less likely to happen, or the patient is less likely to develop an arrhythmia. So if you're seeing a patient that has atrial fibrillation, you will see that the cardiologist will order that. Why? Because he's trying to make sure that this is not the cause of the arrhythmia. All right, that's it. Thank you.